that time. Is Matthias around? Is it okay to start?
Dr. Ishak, please, a minute, let me inform them that you started. Hello, Dr. Ishak.
Hello.
Please, you can start.
Okay, all right, that's fine. So the topic for today is stroke. It used to be called cerebrovascular accident, but now the new term is stroke. So when we say stroke, what does it mean? Who can give us a definition of what stroke is? Anyone to tell us what stroke is? Hello? Is someone trying?
Sir, please, I would say that stroke is a group of conditions which impedes the flow of blood to the cerebrovascular system, which causes a neurological deficit.
Okay, all right. Any add-on?
It's a neurological deficit which happens as a result of occlusion of a vessel or rupture of a vessel in the brain.
Okay, all right. So basically, when we say stroke, stroke refers to sudden onset. So it's a sudden onset of focal neurologic deficit. And this focal neurologic deficit results from interruption of blood supply to the brain. And this interruption of blood supply could either be a vessel being occluded or a vessel getting ruptured. And typically, this neurologic deficit we are talking about usually will last for more than 24 hours. And there's evidence of infarction. If it's ischemic stroke, there's evidence of infarction. If it's hemorrhagic stroke, there's evidence of bleed on the CT scan. So basically, that's stroke. So we are saying it's a sudden set.
Please,
Hello.
Sir, please, you are going a little too fast.
I just started. I'm just giving an introduction.
Yes, please.
So I'm saying stroke is a sudden onset of focal neurologic deficit. And this focal neurologic deficit, we are saying that it's as a result of interruption of blood supply to the brain. And this interruption of blood supply to the brain could either be as a result of an occlusion within a vessel or a rupture of a vessel. And this focal neurologic deficit, we are saying, typically will last for more than 24 hours and is of vascular origin. So that's the general overview. So if you are defining stroke, The key words is it's a sudden onset of focal neurologic deficit. So it just happens. So it's not gradual onset, it's sudden onset. And we are saying it's associated with a focal neurologic deficit. Focal neurologic deficit meaning that it could be that the person is not able to raise the arms, there's loss of speech, it could affect the vision, could affect how the patient walk, the balance. All these are focal neurologic deficits. And it happens suddenly. So it's sudden onset of focal neurologic deficit. And this focal neurologic deficit results from interruption of blood supply to the brain. And this interruption, we are saying, it could either be from an occlusion of a vessel or a rupture of a vessel. And the neurologic deficits we just described, in terms of the duration, usually will last for more than 24 hours. And there's also evidence of infarction on the CT scan for ischemic stroke. There's evidence of a bleed on the CT scan. So basically, stroke is of vascular origin. So when we say it's of vascular origin, it means that there's an issue with the vessel. It's either an occlusion of a vessel or a rupture of a vessel. So someone may have neurologic deficits not because they have stroke, but because they have another condition that is mimicking stroke. So you can have hypoglycemia, and hypoglycemia, the manifestations, you can have autonomic symptoms, and you can also have neuroglycopenic symptoms. As part of the neuroglycopenic symptoms, you can have loss of consciousness, you may have issues with your speech, it may affect your sensorium and all that. All these are neurologic deficits, but it doesn't mean you have stroke. So the neurologic deficit here is as a result of hypoglycemia. So it doesn't mean you have stroke. So someone could also have a seizure when we're talking about epilepsy. After a seizure, you can have paralysis to a part of your body, and that we term as Todd's palsy. So after a seizure, you can have a neurologic deficit. But this neurologic deficit doesn't mean you have stroke. Here, the neurologic deficit is as a result of abnormal electrical firing in the brain. So the seizure caused the paralysis. But in stroke, is an occlusion of a vessel or a rupture of a vessel. So the underlying principle is that all these neurologic deficits are of vascular origin. Please, is it clear?
Yes, sir.
Yes, sir.
Okay, all right. So basically, that's the definition for stroke. So the key was sudden onset of neurologic deficit, focal neurologic deficit, as a result of interruption of blood supply to the brain. Could either be an occlusion or a rupture of the vessel. And the focal neurologic deficit usually lasts for more than 24 hours and is of vascular origin. Okay, so let's look at what TIA is. What does TIA stand for? Anyone to tell us? TIA.
Transient ischemic attack.
Yeah, so transient ischemic attack. How different is that from stroke?
Please, with the TIA, it occurs within 24 hours. It doesn't exceed 24 hours.
Okay. Any other?
There is no
TIA.
evidence of infarction.
There's no evidence of infarction on the CT scan. Okay. All right. Any other add-on?
So it's a neurological deficit that lasts less than 24 hours.
Okay, all right. So TIA stands for transient ischemic attack. So it's just like stroke. Mm. But the difference is that TIA causes focal neurologic deficit that lasts for less than 24 hours. So the focal neurologic deficit that we describe, so some can have loss of speech, paralysis to a part of the body and all that. If it's lasting for less than 24 hours, it's TIA. But if it's lasting for more than 24 hours, then it's stroke. So let's take note of that. These focal neurologic deficits. Even though we are saying lasting for less than 24 hours, most TIAs tend to resolve within 30 minutes. So the focal neurologic deficit, maybe patient came, loss of speech, they are not able to talk and all that. Within the next 30 minutes, the speech is likely to resume. If it doesn't resume, it will last for less than 24 hours. So if it's going beyond 24 hours, then you can't term it as a TIA again. It's now transcended into a stroke. So TIAs also increases your risk of stroke. So take note of that. And the other difference is that there is no evidence of infarction for TIA. So when you do CT scan, you wouldn't see any evidence of infarction on the CT scan. However, for stroke, there's clear evidence of infarction on the CT scan. So these are the basic differences. There are other differences in terms of the management, but the main difference, the duration, in terms of no evidence of infarction on the CT scan for TIA, but you have that in stroke. Is it clear? All right. So I was talking about other focal neurologic deficits that may mimic stroke. So these are the stroke mimics. So whenever someone comes with focal neurologic deficit, you ought to establish whether it's of vascular origin. If it's not of vascular origin, then that condition is said to be a stroke mimic. So someone can have hypoglycemia, present with paralysis, loss of speech. These focal neurologic deficits are not of vascular origin. So they are mimicking stroke. So you call them stroke mimics. The same way epileptic patient can present with paralysis, you may think they have stroke and all that. So all these are stroke mimics if it's not of vascular origin. So that's how you differentiate stroke from stroke mimics. They'll come with focal neurologic deficits, all right. But when you do a CT scan, you wouldn't see any evidence of infarction or bleed. That means it's not of vascular origin. So you may need to investigate for other causes. Maybe it could be metabolic or anything. All right. So let's look at the types of stroke. So there are two main types of stroke. What are they?
Ischemic stroke and hemorrhagic stroke.
Yeah, so you have ischemic stroke and hemorrhagic stroke. All right. So let's take ischemic stroke. So under ischemic stroke, we could also have two main subtypes depending on how the clot is formed within the vessel. Because the vessel, when there is an occlusion in the vessel, we are saying that it causes ischemic stroke. But the nature of the occlusion can give rise to two subtypes of ischemic stroke. So what are the two main subtypes?
The embolic stroke and thrombotic stroke.
So you can have embolic and thrombotic. So when we say thrombotic, Thrombotic means it's from the word thrombus, whereas embolic is from the word embolus or emboli. So basically, for thrombotic stroke, the clot is formed in situ. So it's formed in situ within the vessel. So when you have maybe a damage to the epithelial lining or endothelial lining, the same pathogenesis for MI. So it exposes the underlying collagen. You have fatty streaks coming, you have platelets aggregating and all that. So the damage is within the vessel in situ. So that is how the clot is formed. So the clot is formed in situ within the vessel in the brain. However, embolic stroke, the clot is being dislodged from a distant vessel to block the vessel in the brain. So maybe there's a vessel with a very big clot. Some of the big clots can break off. And the clot that breaks off is what we call the embolus. So the embolus can travel from that distant vessel and go to the cerebral vessel to block any of these smaller vessels. So this is what we term embolic stroke. So the clot is not formed in situ, but it's formed from a distant vessel migrating to a vessel in the brain. So usually we say embolus is a migrating clot, whereas thrombus is a clot that is formed in situ. So these are the two major types. All right, so you can still break it down. Under thrombotic stroke, we are talking about a clot being formed in situ, right? This clot can either block the large vessels in the brain or the small vessels in the brain. So under thrombotic, we can have the small vessel disease in terms of the causes. You can have small vessel disease, and we can also have a large vessel occlusion. So this is under thrombotic. Whereas under embolic, for embolic, what is the common source of this embolus that can cause stroke? What's the common source?
Atrial fibrillation.
Yeah, so atrial fibrillation, so it's coming from the cardiac source. So under embolic stroke, you can have cardioembolic stroke. So if you have a clot formed within the heart, that clot can be pumped by the heart. The left ventricle pumps blood to all parts of the body through the aorta. So that same blood, if it contains a clot, can be sent into the brain to block any of the vessels. So you can have a cardioembolic stroke. Then, if it's not from the heart, how do you term it?
Non-cardioembolic stroke.
So non-cardioembolic stroke. So all these are under embolic stroke. So you can have cardioembolic stroke, non-cardioembolic stroke. And there's one last subtype, which is known as ESOS. So who can tell me what ESOS is? ESOS. So we are talking about embolic stroke. So you can have cardioembolic, non-cardioembolic, and ESOS. So ESOS is embolic stroke of undetermined origin or undetermined source. So we don't know the source of this embolic stroke. So this is what we call ESOS. So it's also one of the subtypes of embolic stroke. So I've mentioned the cardioembolic, non-cardioembolic, and the ESOS.
Doc,
Hello.
please, is the ESOS also known as the cryptogenic?
It's different.
Okay, thanks.
It's different. So cryptogenic is you've done all your investigations. The person has stroke. You've done all the investigation to find out the cause of that stroke. So if you've done all the investigation and you don't find any cause of that stroke, then we call it cryptogenic. But ESOS, you know that is an embolic stroke. Just that you don't know where the embolic stroke is coming from, where the embolus is coming from. But you know it's an embolic stroke. But cryptogenic, you don't know whether it's embolic, you don't know whether it's thrombotic, you don't know the cause at all.
Okay, thanks, Doc.
Okay. So these are the subtypes under embolic stroke. Now let's talk about hemorrhagic stroke. So for hemorrhagic stroke, we could also have subtypes. So here, there's a rupture of a vessel causing bleed, right? But depending on the location of the bleed, we can have subtypes under hemorrhagic stroke. So what are some of the subtypes that you know?
Subdural hemorrhage.
Okay, subdural hemorrhage, yeah, but it's not really one of the main types because it's usually traumatic. So because it's usually traumatic, we usually wouldn't add it to the main subtypes. So there are two main subtypes under hemorrhagic stroke. So what are they?
Intracerebral hemorrhage and subarachnoid.
Yeah, so intracerebral hemorrhage, then subarachnoid hemorrhage. So for intracerebral hemorrhage, basically what happens is there's a rupture of a vessel and the blood comes in direct contact with the brain parenchyma. So the patient bleeds into the brain parenchyma. So that is where the bleed occurs. So intracerebral hemorrhage, patient will be bleeding directly in the brain parenchyma. Subarachnoid hemorrhage. So when you picture the brain is covered by certain structures known as meninges. And these meninges, we have three types of the meninges. So we have the pia mater, the arachnoid mater, and the dura mater. So these are the layers that make up the meninges, the pia mater, the arachnoid mater, and the dura mater. The innermost layer is the pia mater. So that one is very close to the brain. That's the innermost pia mater. And following the pia mater is the arachnoid mater. And the outermost is the dura mater before the skull comes. So this is the graphical representation of the brain. So you have the brain surrounded by meninges, the pia mater, followed by arachnoid. The outermost is the dura mater. The space between the pia and the arachnoid mater is the subarachnoid space. So that's the subarachnoid space, the space between the pia and the arachnoid matter. And this is where the bleed occurs for subarachnoid hemorrhage. So let's take note. For subarachnoid hemorrhage, patients will bleed into the subarachnoid space. That's the space between the pia and the arachnoid matter. The subdural hematoma or the subdural hemorrhage is usually not classified as part of the hemorrhagic stroke, unless maybe it's occurring spontaneously. But if it's traumatic, you wouldn't classify it as stroke. So it may be put under traumatic brain injury and all that. So for subdural hematoma, usually you see that in alcoholics. They tend to fall, they are prone to trauma to the brain and all that. And if you have RTA, road traffic accident too, likely that you may develop some form of subdural hematoma. So the bleed occurs between the arachnoid and the dura mater. So the arachnoid and the dura mater, that space there is known as subdural space. So between the arachnoid and the dura is the subdural space. So if you bleed into the space between the arachnoid and the dura, then we say you have subdural hemorrhage. And if the bleed is occurring between the dura and the skull, then that's epidural hemorrhage. So between the dura and the skull is epidural. All these are not classified as stroke. So epidural, subdural, they are not classified because here it's usually the neurosurgeons that take over with surgical interventions. But stroke, intracerebral, subarachnoid, you wouldn't need any special surgical intervention. Medications is the mainstay. Any questions? All right, so we've talked about what stroke is. We've differentiated between stroke and TIA. Then we've also talked about the various types of stroke. In the definition, we mentioned that stroke is of sudden onset, and we are saying is of sudden onset focal neurologic deficits resulting from interruption of blood supply and all that. And we mentioned something about vascular origin. So let's look at the vascular supply of the brain. Because it's very important. Since you are talking about vascular origin, you should know the major vessels that supply blood to the brain. So there are three major vessels that supply blood to the brain. Who can tell us?
The carotid vessel.
Anyone?
Anterior cerebral artery.
Yeah, so the ACA, which is the anterior cerebral artery. So the ACA. Any other?
Posterior cerebral artery.
Yeah, so if we have anterior cerebral artery, definitely we have what? Posterior cerebral artery. So that's the PCA. What was the last one?
Middle cerebral artery.
Yeah, so the MCA, which is the middle cerebral artery. So these are the three major vessels that supply blood to the brain. The anterior cerebral artery, the middle cerebral artery, and the posterior cerebral artery. The anterior cerebral artery and the middle cerebral artery caters for anterior circulation of the brain. So if you look at the anterior portion of the brain, The major vessels that supply blood is the ACA and the MCA. So the anterior cerebral artery and the middle cerebral artery accounts for anterior circulation of the brain. Whereas the PCA, which is the posterior cerebral artery, accounts for the posterior circulation of the brain. So the anterior portion of the brain is the anterior cerebral artery, the middle cerebral artery. The posterior portion of the brain is the posterior cerebral artery. All right. For the anterior cerebral artery and the middle cerebral artery, they arise from a major or bigger vessel. And this bigger vessel is known as the internal carotid artery. So the ACA and the MCA arise from a bigger vessel known as the internal carotid artery. Whereas the PCA, which accounts for the posterior circulation, arise from the basilar artery and also the vertebral artery. So we said ACA and MCA arise from the internal carotid artery, whereas the PCA arise from the basilar artery. So I've typed them in the chat box. So the basilar artery and the vertebral artery. So if you have any occlusion or any issues with the anterior cerebral artery or the middle cerebral artery, it can cause what we call the anterior circulation stroke. So anterior circulation stroke is when you have interruption of blood supply to the brain as a result of an occlusion or a rupture of the ACA or MCA. So anterior cerebral artery or middle cerebral artery. So if you have an occlusion or a rupture of these two arteries, then we say you have anterior circulation stroke. So your anterior circulation is affected. However, if you have an occlusion or a rupture of a posterior cerebral artery, then we say you have posterior circulation stroke. So let's take note of these terms. Anterior circulation stroke. Issue is ACA or MCA. Posterior circulation stroke. The issue is with the PCA. So these are the major vessels that supply blood to the brain. Is it clear? Any questions? Okay. So let's look at some of the causes of ischemic stroke, then some of the causes of hemorrhagic stroke. So we start with ischemic stroke. So the causes of ischemic stroke are denoted with a certain acronym or mnemonic. And this mnemonic that we use is known as ASCOT. So ASCOT. I've typed it in the chat box, ASCOT. So that's what we use when we are trying to look for the causes of ischemic stroke. We follow the mnemonic ASCOT. So the ASCOT classification of ischemic stroke. So the A stands for atherosclerosis. So A for atherosclerosis. And atherosclerosis, you already know atherosclerosis, where there's formation of plaques in these vessels. For atherosclerosis, it usually affects the big vessels. So it usually affects the large vessel. So the other name for atherosclerotic stroke is large vessel disease. So large vessel disease. Then the S stands for small vessel disease. Small vessel disease. Then the C for cardioembolic stroke. The O is for others. So others. So the others, there are a lot of the others. One of the common ones is vasculitis. Then the D stands for dissections. So that's the Ascot classification of ischemic stroke. I've typed them in the chat box. So the A stands for atherosclerosis. And we are saying atherosclerosis usually would affect the large vessels. So the other name for atherosclerotic stroke is large vessel disease. So if you don't see atherosclerosis, it is the same as large vessel disease. Then the S is for small vessel disease. So if it's affecting the smaller vessels. So aside the ACA, MCA, PCA, these are big vessels, but they give rise to smaller vessels. So if there's an occlusion of these small vessels, then we call it a small vessel disease. Then the C stands for cardioembolic. So if the person has maybe atrial fibrillation, has mitral valve regurgitation, dilated cardiomyopathy, and all that, these are some of the cardioembolic causes of ischemic stroke. Then you could also have O standing for others. So others, there's a tall list of others. So you can have vasculitis, you can have a lot of other conditions, antiphospholipid syndrome and all that. These are all part of the others. Then you can also have D standing for dissections. So you know the vessels, the endothelial lining, we have three types. You have the tunica intima, the tunica media, and the tunica externa. And so you can have a tear within the tunica intima leading to the tunica media. And when there's a tear, you can have an occlusion within these dissections or tears. So dissections are also one of the causes of ischemic stroke. So that's how you run your courses. In trying to find a cause for ischemic stroke, you use the Ascot classification. Now, the patient has any evidence of atherosclerosis. If there is no evidence, you go to S, small vessel disease, O, C, cardioembolic, O, others including vasculitis, then D, dissections. Any questions? All right. So these are the causes of ischemic stroke. The causes of hemorrhagic stroke, we use SMASH U. So SMASH U. So S stands for structural abnormalities. So structural abnormalities. And what are some of the structural abnormalities of hemorrhagic stroke? Anyone to tell us?
Ishak, AV malformation.
Yeah, AV malformation. So arteriovenous malformation. You could also have aneurysms. Aneurysms usually will cause subarachnoid hemorrhage. Mhm. So it's also part of the structural abnormalities. So that's for the S. Then the M stands for medications. So which medications can cause hemorrhagic stroke?
Antiplatelets.
Antiplatelets. What again?
Anticoagulant.
Anticoagulants.
Anticoagulants. What again? So antiplatelets, anticoagulants, thrombolytics, SSRIs, all these can cause bleeding. So medications. Then the A stands for amyloid angiopathy. Amyloid angiopathy. Then the S is for systemic illnesses. So systemic illnesses. Example could be snake bite. So snake bite, a bite from a snake can cause hemorrhagic stroke. So which of the snakes usually causes hemorrhagic stroke?
The ones from the Viperidae family.
Yeah, so snakes from the Viperidae family. So these are the vipers. So when you were learning snake envenomation, they talked about types of venoms. So we have neurotoxic, we have hemotoxic, we have cytotoxic, we have myotoxic. Mm. These are the different types of venoms. So neurotoxic, hemotoxic, cytotoxic, myotoxic. The ones that are hemotoxic tends to thin the blood, and they have the high likelihood of causing hemorrhagic stroke. So the Viperidae, the vipers tend to cause hemorrhagic stroke or bleeding. Then the H stands for hypertension. So hypertension can also cause hemorrhagic stroke. Then the U stands for undefined or undetermined. So these are the causes of hemorrhagic stroke. So for hemorrhagic stroke, we use the mnemonic SMASHU, whereas for ischemic stroke, we use ASCOT. So structural abnormalities, medications, amyloid angiopathy. Amyloid angiopathy, here you have abnormal folding of proteins, and these abnormal proteins are what we call the amyloids. They can deposit in a lot of organs. When they deposit in the brain, they can cause the tendency to bleed in that particular place, and that can lead to what hemorrhagic stroke. Then systemic illnesses, we've talked about it. Hypertension, one of the major cause of hemorrhagic stroke. We have a lot of hypertensives, if they are not really adhering to their medication or their BPs are poorly controlled, the BPs can shoot up and cause a rupture in the vessel. Then, if you run through all these and you don't find the exact cause of the hemorrhagic stroke, then we call it undetermined or undefined. So these are the various causes. Any questions? All right, now let's look at the risk factors. The risk factors for stroke. The risk factors, for every risk factors, remember we have modifiable and non-modifiable risk factors. So that's how you should be approaching them. So modifiable and non-modifiable. So, what are some of the non modifiable risk factors for stroke?
Say age.
Age, that's very true. Mm. So, stroke usually would affect the elderly. As you age, your risk of getting stroke becomes higher. Mm. But that is not to say children cannot get stroke. Children can get stroke. Usually, sickle cell patients, they are prone to getting stroke as one of their complications. You know, the sickling of these RBCs, they are not flexible. They adhere together. You can have clot formation and all that. Hypercoagulability. All right. So sickle cell, they tend to have strokes usually in children. Other than that, for age, most at times is the elderly that will have stroke. So age is a non-modifiable risk factor. But again, any other non-modifiable?
Sir, family history.
Yeah, so family history of stroke. So if you have family history of stroke, the tendency of you also getting it is high, usually from these first degree relative. But again,
Say race and gender.
yeah, so race can also, usually the black race, we tend to get more of strokes compared to other races. Then, is it gender or sex?
Say gender.
Mm, by gender, you're looking at masculine or feminine, or then sex is what, male or female? Or is that not the case? Mm. So, because now people may be males and see themselves to be feminine, and others may be females seeing themselves to be masculine and all that. So, it's safe to use sex. So, sex is also one of the risk factors. So, males tend to get more stroke compared to females. However, if the females get stroke, they usually have worse outcomes compared to the male counterpart. So prevalence is higher in males compared to females, but the worse outcomes is usually more in females. Okay, what again? Non-modifiable. So non-modifiable, at least you should know your age, you should know your race, family history of stroke. Then you also have previous history. So if you've had stroke before, your chances of getting a recurrent stroke is also high. So previous history of stroke. Then low birth weight. So low birth weight, children that were born with low birth weight. There's been some research showing that these population tend to have risk of getting stroke. So you can find out from your parents, your mothers, what was your birth weight when they gave birth to you. That can give you an idea whether you may be at risk or not. So low birth weight is also one of the risk factors, non-modifiable. Then, for modifiable risk factors, what are some of them that you know?
Hypertension.
Yeah, so hypertension, if you have hypertension, you can modify it with medications and so that you don't get stroke. What again?
Cigarette smoking.
This
Yeah, so smoking. So you can modify smoking habits. Smoking habits. So there are smoking cessation programs. You can take advantage of some of these things. But again, modifiable risk factors.
Obesity.
Yeah, so obesity. So you can modify your weight. But again,
Sedentary lifestyle.
so sedentary lifestyle. Okay. Any other?
Poor diet.
You said what?
Sir, please, poor diet.
So which diet will give you high risk of getting stroke?
The fatty meals. And
Okay. Okay, so diets rich in these trans fats, these saturated fats, and um, high sugar, so caloric diets and all that, they tend to increase your chances. What again?
Atrial fibrillation.
Yeah, so atrial fibrillation. Atrial fibrillation. Any other?
Alcohol.
Alcohol intake. Okay. Any other?
High cholesterol.
Yeah, so dyslipidemia. Any other?
The use of oral contraceptives.
Yeah, so the use of oral contraceptives. Any other? So the list is a tall list. So there are lots of risk factors that can predispose you to getting stroke. So you
Dr.
have to
Ishak,
look at.
Okay.
Diabetes.
Dr. Ishak, please, with regards to the modifiable risk factors, you made mention of atrial fibrillation. I want to find out, will permanent atrial fibrillation be classified under modifiable risk factors?
Yeah, they are all modifiable. So all the so far as atrial fibrillation is modifiable. There's a permanent one. The patient and the clinician have decided that they are not going to cardiovert. So they are not going to do anything about it, but it's still a risk factor. That's why when you have atrial fibrillation, you calculate what you call the Chasva score. So if the Chasva score is 2 or more, then your risk of getting stroke is high. So we have to put you on anticoagulation. Aside the two strategic management, the rhythm control and the rate control, the other management is anticoagulation. Once your Chasva score is 2 or more, you qualify to be on it.
Thank you, sir.
Okay. So the modifiable risk factors, there are a lot. Common ones: hypertension, diabetes, sickle cell, dyslipidemia, smoking, obesity, atrial fibrillation. So there is a tall list of modifiable risk factors. So the guiding principle is, if someone has stroke, it's not just atorvastatin aspirin that you give. It's ischemic stroke. No. You have to look out for the cause. Aside the cause, you also have to identify the risk factors. And the risk factors, the one that you can modify, you modify. So if someone gets stroke, and because their stroke was uncontrolled hypertension, and you decide to just manage the stroke, the BP will still be uncontrolled and the patient may end up with another stroke. Or the cause was atrial fibrillation and you just gave your antiplatelets and all that, or maybe anticoagulants, and you don't address the underlying atrial fibrillation, then patient is at risk of another episode. So it's very important to identify the cause and also identify the risk factor so that you modify them in that regard. Any questions? All right. So we've talked about the causes, the risk factors. In the definition, we also mentioned another term, which is focal neurologic deficit. And these focal neurologic deficits basically are the clinical manifestations. So let's look at the clinical manifestations or signs and symptoms of stroke. So what are some of the common signs and symptoms you expect?
Face drooping.
Yeah, so you can have facial paralysis or facial drooping. What again?
Hemiplegia.
Hemiplegia. Okay. What again?
Slurred speech.
Slurred speech. That's true. Any other?
Lip deviation.
Yeah, so you can have lip deviation. Any other?
Hemiparesis.
Hemiparesis. Any other?
Severe headache.
Severe headache. Okay. Any other?
Blurred vision.
Blurred vision. Okay. What again?
Constipation.
Constipation is not a focal neurologic deficit, but it can be a complication of you having stroke. So you can have it as a complication after the stroke, but it's not a focal neurologic deficit. Any other?
Confusion.
Yeah, so you can have altered mental states. So you can have altered mental states. What again? All right, so the clinical presentations are a lot. One of the common mnemonic we use when we are educating patients, especially hypertensive, diabetics, on early detection of stroke is what we call be fast. So be fast. So the B stands for balance. So your balance, if the person is walking and you realize the balance has changed, is tilting to the left or is tilting to the right, or is having these uncoordinated movements and all that, then we say the patient has issues with the balance, so it may be stroke. So B stands for balance, be fast. The E stands for eyes. So you may have issues with your eyes, vision, double vision, blurred vision, and all that. So that's the eyes. Then the F, facial paralysis or facial drooling. So facial dropping or facial paralysis. So you can see that maybe one half of the face is dropping. Mm. So that's facial paralysis. Then you can also have A, that stands for arm weakness. So arm weakness. So a person could able to lift the two arms and all that, but now because of the stroke, he's only able to lift just one arm. So arm weakness can also occur. Then the S stands for speech impairment. It may affect your speech. And the H, I've talked about the F, the A, so the S, that's the speech. Then the T is time to call, and time is brain. So if you don't act fast, you lose a lot of neurons in the brain. So time is brain, time to call. So you always have to be on the lookout. If you see facial weakness, you are seeing issues with the eyes, you are seeing arm weakness, speech impairment, then it's time to call because time is brain. So aside this, there are lots of other clinical presentations, as you rightly said. So the patient may have aphasia. So aphasia meaning that the patient may have speech impairment. Patient may also have dysphagia, difficulty in swallowing. So they may lose their swallowing reflex, for which reason they will pass an NG tube for the patient to enable the patient swallows. So that could also occur. Then, if it's subarachnoid hemorrhage, they usually have the worst headache of their lifetime. So they can have severe headache in terms of their neck. So ideally, your neck should be supple. But for subarachnoid hemorrhage, they usually have neck stiffness. So they may have neck stiffness. They could also present with photophobia. Where there's insensitivity to light and all that. Then they may present with nausea and also vomiting. So these are some of the clinical presentation for subarachnoid hemorrhage. Some strokes may present with issues with balance. Some may present with issues with speech. Some may present with issues with walking, because they may have paralysis and all that. So depending on the clinical presentation, it can give you an idea of what's wrong with the person. But the most common presentation would always be the hemiparesis or hemiplegia. What is the difference? Hemiparesis, hemiplegia.
So hemiparalysis is weakness of one side of the body, and then hemiplegia is paralysis of one side of the body.
Exactly so. So one half of the body, if there's weakness, paralysis, if there's weakness, paresis. But if there's paralysis of one side of the body, then it's hemiplegia. All right. So what if the person is paralyzed from the waist to the leg? How do you call it?
But is it quadriplegia?
No. So paralysis from the waist to the leg.
The waist.
Paraplegia.
So paraplegia. Paraplegia. What if it's paralysis of just one hand? So just your right hand is paralyzed. You can lift your legs, you can lift your left hand, but your right hand is paralyzed. How do you term it?
Monoplegia.
Monoplegia. Monoplegia. What if all your four limbs are paralyzed?
Tetraplegia or quadriplegia.
So tetraplegia or quadriplegia. Okay. What if just your waist to your leg is intact, but your left hand and your right arm are paralyzed?
Please, the question again.
Yeah, so your hands are paralyzed, but your legs are not. How do you term that? So that's what we call diplegia. So diplegia. So if your two hands are paralyzed, your legs are working, diplegia. But if it's the opposite, where your hands are working, your legs are not working, then that's paraplegia. So let's take note of the various clinical presentations. Any questions?
Sir, please, the difference between the paraplegia and diplegia. Please, can you take it again?
So paraplegia, the paralysis is from the waist to the leg. So your hands are active, your hands can do anything, but it's your legs that are paralyzed. But if the paralysis from the waist upwards, affecting the arms, then that one is diplegia. So it's just the arms, but the legs are not paralyzed. That's diplegia. But if the arms are intact and the legs are paralyzed, that's paraplegia.
Thank you.
Any more questions? All right. So I mentioned some of the clinical presentations can tell you what is actually wrong with the patient in terms of the location. So if someone has a stroke and it's affecting their vision, usually which part of the brain is involved if it's affecting the vision?
Said the posterior part.
Yeah, so the posterior cerebral artery may be involved. And usually we are looking at blood vessels supplying blood to the occipital lobe. So the occipital lobe usually is the structure involved. So the occipital lobe. So you may have issues with the vision. If the patient has aphasia, there are two main types of aphasia. What are they?
Expressive and receptive.
Yeah, so we have expressive aphasia and receptive aphasia. What's the difference?
Hello. Okay, so with the expressive aphasia, also called the Broca's aphasia, usually the person will understand what is being said, but there is inability to speak. But for the receptive aphasia or the Wernicke's aphasia, whereas the patient can speak, but it's usually non-coherent or some form of disorientation associated with the speech.
Okay. So with the expressive aphasia, whatever you tell them, the patient understands. So in terms of comprehension, it's intact. Mm. So you try speaking to the patient, they understand. You tell them what they're saying. They will nod with their head. They'll show a gesture showing that, give you a gesture showing that they are doing well and all that. But the issue is their inability to express themselves. So they cannot talk. So you talk to them, how are you doing? They understand everything, but they are not able to express themselves. So you call it expressive aphasia. Comprehension is intact, but the articulation or the speech is where the issue is. So that's expressive aphasia. And usually, expressive aphasia, which part of the brain is affected when you have expressive aphasia?
Sir, please, can I try? I think it's the anterior cerebral artery.
Okay, but you're talking about the structure. So, which particular part of the brain, not the vessel?
Sir, the frontal lobe.
Yeah, so the frontal lobe. Mm. So, the frontal lobe. Specifically, which part of the frontal lobe?
The left frontal lobe.
Yeah, so the left frontal lobe. But which particular portion of the frontal lobe?
The Broca's area.
Yeah, so the Broca's area. So, for expressive aphasia, the issue is the patient understands all right, but there is inability to express themselves. And usually, when you have that, it's telling you you have a lesion in the frontal lobe, specifically the Broca's area. So the Broca's area in the frontal lobe. And we are saying is the left part. When you look at the brain is divided into two main parts. So we have the left hemisphere and the right hemisphere. The left part of the brain controls the right part of your body. So the left part controls the contralateral right part of your body. So it's the opposite side. So we say contralateral part of your body. Whereas the right part of your brain controls the left portion of your body. So that's also contralateral. So if you have a lesion, so if you have a stroke affecting the left part of the brain, the hemiparesis hemiplegia, you see it on the right, not on the same left, unless the stroke is affecting the cerebellum. So for cerebellar stroke, it tends to cause ipsilateral. Ipsilateral is same side. So if you have a lesion at the left cerebellum, it will affect the left part of the brain. If it's in the right cerebellum, it will affect the right part of the brain. Other than that, if it's affecting any part, then it will cause a contralateral or opposite side to be affected. So if it's left part of the brain, you have the lesion or the clinical manifestation on the right. If it's the right part of the brain, the clinical manifestations will be on the left. Are we clear? So the dominant portion of the brain is the left hemisphere. That's why most patients are right-handed, because our dominant portion of the brain is the left, and the left controls the right. So our right is very strong compared to our left. So the dominant portion of the brain is the left, except a few people who are lefties. So those who are lefties, their dominant part is the right portion of the brain. So that dominant right part controls the handwriting and everything, which is done with the left. Other than that, most patients will have their dominant portion being on the right. The dominant portion of the brain being on the left, so they are right-handed. Is it clear?
Yes.
Dr. Ishak, please,
Yeah.
with regards to our dominant part of the brain being the left, it's stated somewhere that the left part is mainly involved in arithmetics and arithmetic solutions and critical thinking, but the right part is mainly artistically biased. So that is it possible that those who are righties are better at artistic skills like arts and writing as compared to critical thinking?
Yeah, it's possible. But for them, their right part is the dominant. So it may be that they may have dominant artistic and features as you are talking about. But in terms of their activities, their dominant portion will be at the right. So we are saying the speech center. So I was talking in relation to the speech center is found at the left. So if we have a stroke affecting the left portion of the brain and the patient is not able to talk, I wouldn't be surprised. But if the lesion is in the right part of the brain and the person is not able to talk, then I'll be surprised because the speech center is in the left. So if the person is a left-handed and he has a lesion in the right and is not able to talk, then we can say that person's dominant portion is the right. So the speech center is likely to be on the right for that person. But most patients will have speech center at the left. So if they have a lesion on the left part of the brain, they are likely to have inability to talk.
So can some patients present with stroke but still be able to talk? I'm
Is it?
asking because most some patients also present the facility with stroke but be able to talk because it's not
Yeah,
affecting
so
their left
it's
or
not all stroke that affects speech. That's why I said the speech center is specifically the Broca's area in the frontal lobe. So if it's not affecting the Broca's area, the patient will be able to talk. All right, so that's for expressive aphasia. We're also talking about receptive aphasia. So for receptive, we said the patient is not able to understand. So here, the issue is how the patient receive information. So the ability to receive information is affected and process them. So in terms of comprehension, it's affected. They don't understand. You ask them, how are you? And they will respond, I've eaten. Or they will respond, I live at maybe Bantama. So they are able to talk all right, but they give inappropriate answers. That inappropriate answers tells you that they didn't understand. So that's why you ask them, how are you? And they are saying they live at Bantama because comprehension is affected. So that is what we call receptive aphasia. So expressive, they are not able to talk, but they understand everything that you say for expressive. It affects the Broca's area in the frontal lobe. Whereas receptive, they are able to talk all right, but they give inappropriate answers. Their comprehension is affected. So they don't understand whatever you are telling them. For receptive aphasia, usually affect which part of the brain?
The Wenix area. In the temporal lobe.
Yeah, so the temporal lobe, and specifically the Wernicke's area. So the Wernicke's area in the temporal lobe. So that's receptive aphasia. So these are the two main types of aphasia that we can have. So if the person, you are talking to the person, they don't understand anything you are telling them, but they are giving you, saying some words and all that, then you think of receptive aphasia, and we are looking for a lesion affecting the temporal lobe. If it is affecting the temporal lobe, you are likely to have this receptive because of the um, Wernicke's area. Whereas if they are able to understand all right, but they are not able to talk, then you look for a lesion in the frontal lobe. So that is the expressive aphasia. Is that clear? Okay, all right. So these are some of the clinical presentation. So if it's affecting their balance, they are having ataxia and all that, you think of cerebellum being affected. So the cerebellum controls your balance and all that. So if there is a lesion affecting the cerebellum, then you can have ataxia, issues with balance. If it's affecting the frontal lobe, aside the speech, the frontal lobe controls the executive functions of the brain. So your ability to do cognitive or the ability to process these high thinking, high learning and all that, you need a frontal lobe. So if you are asking them common things, maybe 2 times 16 or something like 2 by 10, you're expecting them to give you an answer and they are giving you something else. Then you know that maybe the executive function may be affected. Then if the person is not able to, maybe the hands are intact, the patient is able to lift the arms and all that, but the legs are paralyzed. Then you think about the ACA. So if you have an occlusion, a rupture of the anterior cerebral artery, so the ACA controls your legs. So if you have an occlusion or a rupture of the ACA, then you may have paralysis on the leg, but your hands are likely to be active. So these are some of the dynamics that we look out for. All right. Now let's look at diagnosis. So for diagnosis, as usual, the first thing you start with is history. So any patient who is coming to you with focal neurologic deficits and all that, you want to find out how it started, what are some of the signs and symptoms. So history is very important. You also want to find out your drug history, past medical history and all that. If you don't find out history and the patient, you just go straight and do CT scan, you've seen hemorrhagic stroke. It may be that this patient in front of you may have been bitten by a snake. And because you just did CT scan straight away, you didn't look at the cause, then you may treat it as a normal hemorrhagic stroke. Meanwhile, if a snake bites, the first thing you need is your anti-venom. So your anti-snake venom to neutralize the hemotoxin before you even think of any other thing. But because you didn't take history, you just did CT scan, you've seen hemorrhagic stroke, so let's just treat as hemorrhagic stroke. So history is very, very important whenever you want to take or you want to diagnose a certain condition. Aside the history, you can do the clinical examination. Here, the clinical examination, you want to check the level of consciousness. So we want to do GCS to check the level of consciousness of the patient. Then we also check for we also do neuroexamination, where we check for the power of the limbs, the tone, and the reflexes. These are very common tests that we do at the bedside. So power usually scored over 5. So if we see 5/5, then that means the patient has full power. There is no hemiparesis, there is no hemiplegia. If you see 4/5, then there's hemiparesis. 3/5, hemiparesis. 2/5, hemiparesis. 1/5. All these are hemiparesis. But when you see 0/5, then that person has hemiplegia. So that part is paralyzed. So that is hemiplegia. But if there's some form of power, but it's not up to 5/5, then you may be having hemiparesis. So that's the difference between hemiplegia and hemiparesis when you are using the power. Then they also check for the tone, the muscle tone, and all that. Then the reflex. So this is what we call the Babinski reflex, where they use the pen or their patellar hammer to elicit some friction on the plantar of the foot. So they draw like the correct sign on the foot and try to see how the toes will move. So if you put a pen at the sole of the feet and you draw the correct sign, realize that for a normal patient, the toes are flexed forward. So that's a flexor response. So that's a normal response. However, the person has any lesion in the brain. It could be stroke, it could be any other thing in the brain, CNS infection, toxo, tumor, and all that. You realize that the patient toes will flex backwards or will extend backwards. So that's what we call extensor. So whenever there's extensor or the right Babinski reflex positive, then it shows that the patient has an issue in the brain. But if it's flexor, then it's normal. So these are clinical examinations that are done at the bedside. However, all these wouldn't help confirm the diagnosis of stroke. So what confirms the diagnosis is CT or MRI. So you can do a CT scan or MRI. So for ischemic stroke, what do you expect to see on the CT scan?
Say you see hypodense lesions.
Yeah, so you see hypodense lesions, and these will appear as dark patches on the CT scan. So the dark patches you see on the CT scan are known as hypodense lesions. What about hemorrhagic stroke? What do you see?
So hypodense lesions.
So that's hyperdense lesions. So these are the white patches you see. So when you see the white patches on the CT scan, then it's likely to be hemorrhagic stroke. When you see the dark patches, which are the hypodense lesions, then it's likely to be ischemic stroke. So these are what we use in diagnosing whether it's ischemic stroke or hemorrhagic stroke. The signs and symptoms may tell you there's stroke. Stroke is a clinical diagnosis. So the signs and symptoms can tell you it's stroke, but you need the CT scan to confirm whether it's ischemic or hemorrhagic. The clinical signs and symptoms wouldn't tell you it's ischemic or hemorrhagic. It will tell you the patient has stroke. But to confirm that particular type of stroke, you need to take imaging of the brain, and that will tell you whether it's ischemic or hemorrhagic. Any questions? Any
Doctor,
questions so far?
please, at what point you choose to do the MRI instead of CT scan?
Yeah, so the CT scan, usually within the first 24 hours of onset of ischemic stroke, the CT scan is likely to miss it. So in terms of the imaging of preference, within the first 24 hours, it's better to do MRI. But after 24 hours, then you can do CT, because at that time, if it's ischemic stroke, you pick it on the CT scan. If it's hemorrhagic stroke, you can never miss it on the CT. So whether you do it early or not, hemorrhagic stroke, you see, is very clear white patches on the CT. But the dark patches, you may not see it for ischemic stroke if you do it too early within the first 24 hours. Because if the stroke is a very small one, usually the small vessel disease, the other term is lacuna. So on the CT scan, the infarct size will be less than 1.5 centimeters. If the infarct size is less than or equal to 1.5 centimeters, then the patient has a lacuna stroke or a small vessel disease. If it's above 1.5, then we are looking at either cardioembolic or large vessel disease. So for the very small lesion within the first 24 hours, you are likely to miss it. But MRI has a better resolution. So you are likely to pick it. Any
Thank
other question?
Hello, sir.
Hello.
Please, at the ward, I realized that what the medical doctors were doing was that sometimes they knock very hard on the chest and they will say that the deficit is at the left or the right. Or sometimes they rub very hard and you hear that the patient will scream. So, what were they trying to do and what's the meaning of the deficit at the left or the right? Thank you.
So basically, they are trying to check the GCS. So when you are checking GCS, you look at motor, verbal, and also eye. So if the patient is at the bedside, you first call out the patient's name to see if the patient would open the eyes, would move the arms. You call the patient name to see whether they'll open the eyes, especially if you come and they are sleeping. If you call and they are not opening their eyes, then it's likely they may not move their arms. But if they are moving already, fine. But if they are not moving, you can't score for the GCS. So you provide what we call a sternal rub. So the sternal rub is when they make a fist and they rub the chest. So they rub the sternum. So whilst rubbing the sternum, they want to find out how the patient will respond to a painful stimulation. So the first one was verbal, to see whether the patient will respond. If the patient is not responding, they provide a sternal rub, which is a painful stimulation, to see whether the patient will open the eyes. If they open the eyes spontaneously, then they have a score for it. If they open the eyes with sternal rub or painful stimulation, they have a score. If they don't open at all, there's a score. Then whether they raise, because if you are providing that sternal rub, the patient will try to, because it's painful, the patient will try to restrict. And by doing the restriction, they use their arms. So if the arms are strong, you realize that the patient may use the two hands to try and restrict you. But if maybe the left is weak, it's only the right that the patient would lift to try to restrict that sternal wrap. Then the verbal two, you want to find out whether they are able to talk. So if they are providing that sternal wrap and they are talking, they are saying Ajay, Ajay, they are making some sound, or they are saying stop and all that. It's all ways of scoring the GCS for the patient.
Okay, thank you, sir.
Okay. Any more questions? Okay. So we are about to start the management, but we'll end here. Then Tuesday, we'll talk about the management. So that will be our last meeting, which is on Tuesday. If there are no more questions, we'll end here. Any more questions? All right. So have a good evening.
Thank you, Dr. Isha.
Okay.